We are live.
A very good evening, everyone. Welcome to iFocus Online, lecture 236, number 23 in our series from Squint and Paediatric Ophthalmology. Today, we have with us Dr. Swati Phuljhele from RP Center AIIMS, New Delhi, talking to us on third nerve palsies, the etiology, diagnosis, localization, and management. I would like to invite Professor Pradeep Sharma, sir, to welcome her and introduce her to our audience.
Thank you, Dr. Shefali. It's really a great pleasure to introduce Swati, who has been with us in RP Center for a long time as a colleague, and she has been a brilliant student and then later a faculty. It's really a pleasure that she'll be talking on third nerve palsy, which is another subject which is very dear to us. She did her MBBS from Jawaharlal Nehru Memorial Medical College, Raipur, and then her MD from RP Center AIIMS, New Delhi. And currently she is the additional professor at RP Center AIIMS. She was a senior research associate in neuro-ophthalmology and strabismus services for 2009 to 2011, a research officer in the IND-I study of cataract and age-related macular degeneration in 2009. She has several awards and accomplishments, including the winner of ARC Young Research Session in AIOS annual meeting in 2006, assistant editor 2007 and 2008 of the Strabiscope, the newsletter of Strabismology Society of India. She has been a reviewer of articles of several national and international journals, many national and international publications to her credit. So it is going to be a great pleasure for us to all hear Dr. Swati speak on third nerve palsy. Dr. Swati, the floor is yours.
Thank you, sir. Thank you for that introduction. It's always an honor to be in your presence only. So speaking in front of you indeed is a big honor, and whatever I've learned from you only. So I'll be today talking about third nerve palsy. Before that, I would like to thank Dr. Honavar for giving me this opportunity, and to the huge audience who is there to listen to this talk. Thank you, everyone. So to begin with, third nerve, as we all know, supplies to almost all extraocular muscles in the eye, excluding superior oblique and lateral rectus. So it's very interesting to know the anatomy of third nerve, which itself is very complicated and even though intriguing. So the cell body of the third nerve, or the nucleus of the third nerve, lies at the level of superior colliculus in the midbrain, and it's a nuclear mass which is straddling the vertical midline. So if you can look at this diagram, it can show that there is a central, there is a nucleus, Edinger-Westphal nucleus, which is a parasympathetic nucleus, supplies to pupilomotor fibers. Then there is a caudal nucleus, which is a single nucleus for both LPS. There is nucleus for superior rectus on each side, nucleus for inferior rectus each side. So these are paired nucleus on either side of the midline for each muscle: superior rectus, inferior oblique, and medial rectus. So it's important to understand that, because the significance of this I'll be talking about when we discuss the clinical features of third nerve palsies in subsequent slides. So once the nerve is formed, it exits the fascicle, passes through the red nucleus, through the cerebral peduncle into the subarachnoid space. Here, the subarachnoid space, it is related to multiple structures, multiple vessels, and it's quite susceptible to number of things. After leaving the subarachnoid space, it pierces the dura and enters into the cavernous sinus, and gets divided into the cavernous sinus into two divisions: the superior division and inferior division. Here also it is related to important structures, particularly other cranial nerves like fourth nerve, fifth nerve, and sixth nerve, along with the sella and internal carotid artery. From the cavernous sinus, it then enters into the orbit through superior orbital fissure as two divisions of superior division and inferior division. So as we all know, superior division supplies to LPS and superior rectus, while inferior division supplies to rest of the muscles, including the pupillary fibers. So to classify third nerve palsy, it can be congenital and acquired. The other way of classifying it could be pupil involving or pupil sparing. Another way of classifying it could be complete or partial. So congenital third nerve palsy is generally because of the maldevelopment of third nerve nucleus, or the nerve itself could be secondary to birth trauma. What is interesting to note that is it forms half of the third nerve palsies in children. The other common cause in children is of course trauma. And many of these patients will show aberrant degeneration in some or the other form. Acquired third nerve palsies, the clinical features will depend on the location of the lesion, and that's what we need to understand whenever we see a case of third nerve. So the nuclear lesions, as I was talking about, that there is a central nucleus for LPS, and rest of the muscles have paired nucleus on the either side of midline. What is interesting to note that the LPS receives supply from a single nucleus, while the superior rectus muscles receive supply from the contralateral nucleus. So that's why if the lesion is there at the nucleus, you will have bilateral ptosis because of the single nucleus, and you will have contralateral superior rectus palsy. It's also important to note that this parasympathetic nucleus is at the rostral part of the midbrain, while the LPS nucleus is at the, or the caudate nucleus is at the caudal part. So if the lesion is rostral enough or dorsal, it will cause a pupillary involving third nerve palsy, and ptosis may be absent in such cases. While if the lesion is caudal involving LPS nucleus, then the then the third nerve palsy may spare the pupil. So depending on the kind of pupillary involvement, pupillary sparing, or depending on the involvement of contralateral superior rectus or bilateral ptosis, one can localize the lesion at the level of nucleus. So causes at this particular level include infarction, infection, inflammation, compression, hemorrhage, and rarely demyelination also. So the most common cause here still remains the infarction, and sometimes the lesions are so small at the midbrain that it may be difficult to find them on the regular imaging. So coming to the fascicular lesions, again the common cause is infarction, and it is secondary to the vascular injuries to the area supplied by basilar artery as well as the area supplied by the posterior cerebellar artery. The other common cause could be hemorrhage in this area. So as you can see, this is a very, very crowded area. There are a lot of structures over here. You have red nucleus, you have longitudinal, medial longitudinal fasciculars, then you have here posterior commissure. So other nucleus, other structures are also here. So small infection here followed by a surrounding edema can lead to varied kind of clinical features. So just to describe some of the very common syndromes which are seen with third nerve palsies are when there is involvement of red nucleus, one can see that there is contralateral extrapyramidal symptoms, also known as Benedict syndrome. If there is an involvement of corticospinal tract along with the third nerve palsy, so the lesion will be somewhere here. What we get is a Weber syndrome, classically third nerve palsy with the contralateral hemiparesis. At this area, the third nerve may be related to superior cerebellar peduncle as well, and when we get the ipsilateral ataxia along with third nerve palsy, also known as Nathanael syndrome. So at subarachnoid space, most likely it may be an isolated palsy, and it may present in three ways. Particularly, there may be an isolated pupil involvement. There may be isolated pupil sparing with ophthalmoplegia, and ophthalmoplegia with pupillary involvement. And all of these have their own significance. So before we understand how it is important, what is the significance of each of them, it's important to understand the basic structure of the third nerve. So if you consider this as a complete third nerve, you have the pupillary motor fibers, which are superficial, followed by the ocular motor, which are inside the pupillary motor fibers. And in the center, there is the vasa nervosum, the vessels which supplies the entire nerve. So in case there is any lesion, compression lesion and extrinsic lesion which compresses on the nerve, the chances of pupillary fiber getting involved are very, very high. So you will get something as pupil involving third nerve palsy. If there is ischemia or infarction due to vasa nervosum involvement, Then what generally these are the oculomotor fibers are the ones which get more involved as compared to pupil fibers. And what you get is a pupil sparing ischemic, pupil sparing third nerve palsy. So in subarachnoid space, as I said, it is related to multiple structures, particularly multiple vessels, and then therefore it is susceptible to aneurysm from different vessels. So aneurysm definitely is the most common cause of third nerve palsy in this area, followed by microvascular occlusion, which may be because of diabetic, hypertension, or other risk factors. Neoplasms anywhere in this area can also cause compression, trauma, and of course the herniation of brainstem. So isolated pupil involvement is a very early sign of compression, and one should be cautious enough to pick it up in early stages. And if it's picked up at that stage, it definitely can be life-saving, because otherwise it may lead to intracranial hemorrhage due to aneurysms or other complications. So this is just one patient which I had with me. So this is a case of, as you can see, there is clearly a pupil involvement, there is complete third nerve palsy, and there is anisocoria. This lady presented with acute neurological dysfunction, headache, neck stiffness, and early pupil involvement. Although by the time she presented, it was very late, because she anyway presented with significant neurological dysfunction. So we should avoid patient to get into this stage and should be able to pick this kind of anisocoria in the early stage. So this is a CT scan which shows brain hemorrhage. Of course, this picture does not belong to this patient. This is just for the representative purpose, that if, doing MRA in such cases is very important when you want to pick up those small aneurysms over there. So as I was saying, there are multiple aneurysms that can cause third nerve palsy, as it is related to many important vessels, arteries, superior cerebellar artery, basilar artery, of course, posterior communicating artery here is the most common cause of the aneurysm, which can compress the third nerve. Then of course, cavernous carotid fistula. Other than pupillary involvement, early pupillary involvement, you may have pupillary involvement along with ophthalmoplegia, and again here the most common cause remains compression only. So aneurysms, tumors, fistulas, tentorial herniation is all are the all causes which can cause third nerve palsy. Trauma at this stage is also very common, because third nerve is very susceptible to trauma. Then vascular diseases may also cause, sometimes may also cause pupil involvement. Then isolated pupillary sparing external ophthalmoplegia is commonly associated with ischemia, and patient may give history of risk factors in form of diabetes, hypertension, or other atherosclerotic disease. So here is one such patient who presented with ophthalmoplegia of right eye, and one can see that pupil in this particular case is spared. She had history of hypertension and diabetes for few years, which was uncontrolled and has led to this kind of clinical picture. So these are the patients where you can probably allow yourself a little relaxation and may not jump into imaging immediately, but of course you have to follow them cautiously and keep checking their progression subsequently. So at the level of cavernous sinus, third nerve is particularly vulnerable to injuries at its entry, and therefore trauma is the most common cause of third nerve palsy at this stage. However, the trauma has to be severe enough to cause unconsciousness and to cause some kind of fractures, so that the third nerve can get involved. Any kind of third nerve palsy in absence of severe traumas or significant traumas may arouse the suspicion of any kind of compressive lesion, and thus they should be evaluated appropriately. So once the third nerve enters the cavernous sinus, it is, as I said, related to multiple important structure, including pituitary gland, other nerves, and so therefore it is susceptible to cavernous sinus thrombosis, any neoplasm there, inflammation, aneurysms. Again, internal carotid artery is very closely related. So internal carotid artery aneurysm can cause third nerve palsy, microvascular occlusions, and AV fistulas. So this is another such patient who presented to us with ophthalmoplegia, and this time pupil were involved. So there was no history of any vascular risk factors suggestive of microvascular occlusion. So we went ahead, did imaging, although NCCT may not be a good idea, it may not be a great idea to pick up small subtle adenomas at this stage, but however, since this patient already carried this CT scan, we found that there was a pituitary adenoma. At the cavernous sinus and the superior orbital fissure, the clinical presentation more or less remains same. And since there are other nerves involved also, so there may be combined paralysis of other nerves like trochlear nerves, abducens nerve, and also sometimes there is involvement of divisions of trigeminal nerve. So it's important to check for all other muscles as well, and also important to check for corneal sensation to localize the lesion at this particular level. So orbital lesion, when third nerve moves forward, it is closely related to orbital optic canal, and where there is optic nerve as well as central retinal artery. So if you have optic nerve involvement along with the third nerve palsy, probably the lesion is localized at the orbital apex, and the common cause here include mass lesions, any kind of inflammation, and very rarely trauma. The clinical presentation at this stage will include proptosis along with the vision loss, and sometimes there may be involvement of other nerves as well. So this is a case of classical case of orbital apex syndrome, where you can see it's not just the third nerve, but all other cranial nerves are also involved. There is decreased corneal sensation, and on imaging MRI, you can see that there is a lesion here at the apex, which is coming from the maxillary sinus. So this is a compressive lesion here. So this is how you can localize the lesion at the level of orbital apex. Sometimes it may be secondary to inflammatory conditions or infections like herpes zoster. So this particular case shows the right eye complete third nerve palsy involving pupil due to herpes zoster. So coming to partial third nerve palsy, as I said, there can be a complete third nerve palsy or a partial third nerve palsy. So instead of the entire third nerve, there can be involvement of one particular division of third nerve, which can be superior division or inferior division, depending on the site of the lesion. And depending on which division is involved, one may have the clinical features. So if the superior division is involved, it is classically, because it will classically present as the elevation defect and ptosis, while if the inferior division is involved, you will have the pressure effect, you will have an isochoria, and ptosis will be absent. Then there can be isolated muscle paralysis because of the inflammation or trauma or direct injury to the muscle, direct trauma to the muscle. So these things can occur. So this is just to show a picture of a patient who presented to us with the adduction deficit, and you can see that there was a medial wall fracture along with the disinsertion of the medial rectus muscle, leading to adduction defect. Another patient again presenting with adduction defect, isolated medial rectus palsy, and we found out that there was a cystic circus there which needs to be treated medically. Then this is another interesting case where you have an isolated medial rectus or adduction paralysis. He was a 58-year-old male who presented with diplopia, particularly on the left gaze. So there was a history of diabetes for 10 years. So on the first look, it looks like that probably it's a vasculopathic third nerve palsy, because there is no involvement of pupil and patient has history of diabetic. But one has to notice that there is just a small limitation of adduction there in the right eye. So if you look at this video, you can see that even though there is an adduction deficit, the patient can converge very well. So such kind of isolated medial rectus palsy, which you have convergence paired, are localized to midbrain, particularly internuclear ophthalmoplegia, involvement of medial longitudinal fasciculars. So when we went ahead and did imaging, this is what found: a small focus of infarction there, suggestive of which can explain this kind of presentation. Along with isolated abduction paralysis, this patient also have contralateral abduction nystagmus. So this is just to summarize how you localize third nerve palsy. So if it's a nuclear third nerve palsy, it is generally a complete third nerve palsy with bilateral ptosis and contralateral superior rectus weakness. And these are the common causes for the nuclear involvement. If it's a fascicular third nerve palsy, you have contralateral hemiparesis, whether if the corticospinal tract is involved, known as Weber syndrome. You may have extrapyramidal symptoms known as Benedict syndrome, and you may have ataxia because of the cerebellar peduncle involvement known as Nathaniel syndrome. The common causes again at the level of fascicle include vascular occlusion, hemorrhage, neoplasm, and demyelination. Then at the subarachnoid space, the most important thing is to do the pupillary examination, because at this level, it is not associated with any other neurological syndrome. So such a case may be difficult to localize a lesion if one is not careful enough, and if not, proper neuroimaging is not properly done. So it's important to check for pupil involvement. The causes again remain same as that of fascicular involvement. At cavernous sinus, there may be involvement of other cranial nerves. So it's important to look for corneal and facial sensation to see the involvement of trigeminal nerve. Also look for the other cranial nerve involvement. Then at orbit, there will be proptosis, there will be visual loss. Again, check for the corneal sensation, look at the vision, and will give you localization at the orbit. So how do we clinically evaluate? So that was how you localize a lesion. But apart from that, clinically, there are certain things which you want to consider for from the management of point of view, from the surgical surgery point of view. So you should take the proper history of headache, particularly compressive lesions, history of vascular risk factors, history of nausea, vomiting, or any other disorder which may suggest, any other neurological symptom. So classically, it presents as a divergent strabismus with only abduction preserved and probably superior oblique movement preserved, which I'll show in subsequent slide how to look for it for the postgraduate students. Pupil should be checked. If it's a complete pupillary involving palsy, of course, pupil would be fixed and dilated, and there'll be loss of accommodation, there'll be ptosis, and it can present as various part of various syndromes. This is just to show how a Hess chart will present for third nerve palsy. So it's a small chart over here where all other movements are restricted. This video is just to show how you can check for superior oblique movement in presence of third nerve palsy, because the eye is unable to adduct. So doing an examination, asking patient to look from up gaze to down gaze, you may see that there is a torsion of the limbal vessel over there, which suggests that it's the normal functioning superior oblique. So you should also look for the aberrant degeneration, which is very, very important. So in this case, you can see this is a case of post-traumatic third nerve palsy with aberrant degeneration. The left eye, otherwise in primary gaze, has ptosis, but on adduction the ptosis improves. So this is one of the form of aberrant degeneration, which is due to a misdirection of the axons, which regenerate after the trauma. Other presentation of aberrant degeneration could be elevation of lid in down gaze or in up gaze. So the fibers which are directed to inferior rectus or in superior rectus are also supplying the lid. There can be pupillary constriction with adduction or elevation, depending again on the misdirection of the nerves. And adduction along with the attempted up gaze or down gaze. So there can be miswiring between the superior rectus and the medial rectus, or inferior rectus and medial rectus. So whenever patient look up or down, there is adduction. However, the important thing to note is that apparent regeneration, if it's an acquired third nerve palsy, and apparent regeneration is seen in absence of significant trauma, one should suspect a compressive lesion there and should investigate the patient accordingly. So coming to role of neuroimaging, it is essential to rule out mass lesion as a cause of third nerve palsy. And particular indications include if the patient is young and there is involvement of pupil. If the patient is more than 40, again, if there is involvement of pupil, it becomes an indication for neuroimaging. As I emphasized earlier also, if there is aberrant regeneration with either no history of trauma or history of very minor non-significant trauma. So this is how you will approach a case of third nerve palsy. You will check the pupil. If the pupil is spared, then you check the amount of ophthalmoplegia. So if the ophthalmoplegia is partial, it could still be an evolving complete third nerve palsy, and these patients do require immediate imaging in form of MRI and MRA to rule out any aneurysm. If pupil is spared and patient has complete third nerve palsy along with the history of vasculopathic risk factors, then probably these patients may be followed up and look for improvement. If there is no improvement on subsequent monthly follow-up or 2-monthly follow-up, one should definitely revisit the diagnosis and get a neuroimaging done. If pupil is involved in the beginning with or without ophthalmoplegia, of course, imaging is required, particularly in young patients. Then coming to the management of third nerve palsy, if it's a congenital third nerve palsy, probably early surgery helps to prevent amblyopia. But again, it will depend on the extent of the involvement, whether it's a partial or a complete pupil involving, pupil present, ptosis, and everything has to be considered whenever we deal with a case of third nerve palsy. So non-surgical management is a temporary measure till the nerve regenerates, till the deviation stabilizes. So we can use prism, segmental occlusion devices, or a complete occlusion to avoid diplopia. Then Botox can also be given just till the deviation is stabilized. And coming to the surgical management, so the aim is to get the binocular single vision in the primary gaze and to align in down gaze, because these are two important gazes which we use in our day-to-day life. So one has to be clear that not all the deviations, all 9 gazes can be corrected with the surgery, and patient should be counseled realistically for that. So it's important to wait for 6 to 8 months before the stabilization of deviation, because most of the vasculopathic third nerve palsies do improve over a period of time, and if all the risk factors are under control, they do not need surgery most of the time. While the traumatic cases, it's again important to wait, because you want to allow for regeneration of the fibers and want to look for how the end presentation would be, so that the deviation is stabilized. So this is just to show that this patient has complete post-traumatic third nerve palsy, which recovered over a period of time, and these are the patients who don't require surgery, and that's why it's very, very important to wait before we jump to surgery. So if it's an isolated or a partial third nerve palsy, depending on the amount of involvement, so if it's a vertical rectus involvement, you can do the transposition procedures. So if it's again just the if both the vertical, superior rectus and inferior rectus muscles are involved, then you can do the contralateral vertical posterior fixation. If it's an isolated medial rectus palsy where both vertical recti are intact, then both of them can be transposed to the MR. So this picture is to show the isolated SR palsy, where you can see there is a significant elevation deficit. However, other muscles are good enough, are not involved, and therefore transposing both medial rectus and lateral rectus superiorly will help in improving the elevation as well as improving the bells. In cases of complete third nerve palsy, the options are definitely limited and results may not be very satisfactory. So depending again on the clinical presentation, if there is a good MR function, if there is a recovered third nerve palsy with residual deviation, with good MR function, a supramaximal resection of the MR and LR can be done. Transposition of tendon can be done if there is no MR function. And periosteal anchoring is done as a last resort when we know that none of the muscles can be transposed to medial side. So this is a patient in which who had third nerve palsy, left eye with good adduction. If not complete, the adduction was good. The eye was able to cross the midline, and there was just a -1 kind of limitation over there. So in such cases, you have to do a recession of lateral rectus and resection or strengthening of medial rectus in form of plication or resection in that eye. It's also interesting to know that we can use this aberrant regeneration in our favor to get the improve the ptosis as well. So in this particular case, as you can see that on adduction, the lid could elevate, and therefore we did the other eye contralateral resection to create the fixation duress, and the post-op we can see that the ptosis was also improved. So that's one of the way to take the advantage of aberrant regeneration. So periosteal anchoring is a kind of a surgery which we want to do at the end when all other measures fail, and the globe has to be anchored at the medial canthus or the medial orbital wall with the help of fascial lata superior oblique tendon, or just a non-absorbable suture. This is just a technique which was published in JAPOS to show how globe can be anchored medially. So this is a case of third nerve palsy where the large LR recession was done because FGT was tight, and you have to release that FGT before you do any other procedure on the medial rectus, or even if you want to do an anchoring procedure, you want to release the FGT first. So here the large lateral rectus recession was done, and the globe was anchored to the medial wall, and post-op, of course, there is an alignment, but it comes at the cost of loss of ocular movements in all direction, including abduction. So this is another case where we did medial rectus anchoring. So you can see that the primary position alignment is good enough. So apart from medial rectus, medial globe anchor, we now have another surgery in our armamentarium, which is transposing lateral rectus to medial rectus. So if the FGT is not tight, that means that you can move the lateral rectus to the medial side, and it can harness the globe in the primary position. And that can be done as either you can split the lateral rectus into two limbs and then transpose both of them superiorly and inferiorly, or depending on the associated accompanied vertical deviation, it can be a superior entire belly of the lateral rectus can be transposed superiorly or inferiorly, depending on the vertical deviation you have associated with the horizontal deviation. So it's not just important to manage the deviation, it's also equally important to manage the ptosis. So if the Bell's phenomena is good as in isolated superior rectus palsy, You can do NAPS procedure, and if that improves the bell, yes, ptosis surgery can be done. But in most of the cases, in a case of complete third nerve palsy, probably one cannot give much hope to the patient regarding the ptosis management, and crushed glasses remain the only choice. So that's all for the management of third nerve palsy. I hope I have completed almost everything. Thank you for your patient listening. Thank you, everyone.
Thank you so much, ma'am. That was a very comprehensive talk on third nerve palsies. Pradeep sir, any comments from you, Amitava sir?
I think it's wonderful. I think it's one of the best lectures on third nerve palsies, Swati. So really, I congratulate you.
It means a lot.
Doing such a comprehensive coverage. You have very nicely spoken about the different types of third nerve palsy, the nuclear versus fascicular, the pupillary sparing versus non-pupillary involving, and very schematically showing for the PGs how and why this happens, and also the internuclear ophthalmoplegia, the importance of convergence by the video. Localization of third nerve palsy is very important. This is one of the nerve which has such a comprehensive spread. I mean, if you ask a PG, which are the muscles supplied, he usually resorts to the shortcut and he says, all muscles except superior oblique and lateral rectus. So, I mean, that shows that all the extraocular muscles are involved, including the LPS, including the accommodation muscles, which also you mentioned that the PG should never forget to look into the accommodation to see the near vision. If it's a younger adult, you will be able to see that the near vision is affected compared to the other eye. And again, the management also, you have very comprehensively covered. So let's hear some views from Dr. Amitava, and then we can move on to the questions from the audience.
No, I will second Professor Sharma that this was an excellent presentation, and I think very comprehensive.
Thank you, sir. Thank you,
Yeah,
sir.
but I just let me add one little interesting point, because this is what postgraduates are always looking for, something different. You see, when so I tell them that this oculomotor nucleus is not a nucleus; it's a bunch of grapes actually, and some of those grapes are fused.
Yeah, that's true.
Yeah, and the interesting thing is that the medial rectus subnucleus, therefore, when it supplies the contralateral superior rectus, it goes through the bunch of nuclei of the contralateral side.
Yes.
Okay. Now, when it does that, so even if you have a nuclear involvement which is on one side, it will invariably affect both the superior recti.
Yes.
Postgraduates need to understand that you will get a superior. It's not just the contralateral supply here. So because the nucleus involvement on the left, the contralateral, the right superior rectus will go, and the right superior rectus subnuclei is sending its wires through the left side. So even those wires will go. So both the superior recti can go with nuclear involvement.
Yes, sir. That was just to emphasize that you should check for the contralateral superior rectus,
so
along with the third nerve, complete third nerve palsy on that ipsilateral side.
Quite right. And I'm not sure, but they would mention in those midbrain syndromes even Claude syndrome, where they would say that it's just more than Benedict and this combined.
Yes, it's combined of Benedict and Weber's. Yes.
Okay.
Ma'am, I'll just quickly request you to stop sharing the screen, and then I'll move on to the question.
Yeah.
The first question from our audience is, in a patient with no prior history of diabetes or hypertension presenting with features of third cranial nerve palsies, which subset of patients should we advise neuroimaging?
That depends on number of risk factors. As I said, number one is age. If the patient young enough, so whether pupil involved, risk factors present, not present, you have to do neuroimaging. So if the patient is old enough where you suspect there can be a history, you may first rule out these risk factors and again note whether there is a complete third nerve palsy, which is sparing pupil, or a third nerve palsy, which is involving pupil and still in evolving stage. Then you have to do neuroimaging. I'm sure sir would like to add anything, or Dr. Amitava.
I think that's right. Basically, you would have to see if there is a partial third nerve palsy. You need to keep an observation. Call the patient another 3 days later and see if you have pupil sparing initially, but in 3 days' time, if it is coming up that the pupil is getting involved, it may be an indication for imaging, even though he is an elderly person in whom you had initially suspected an ischemic lesion. So even the elderly people can have tumors, even the elderly people can have compressive lesions. So it doesn't spare them. So that is what you have to keep in mind. If it's a partial third nerve palsy, you definitely keep a watch on the possibility of evolution. So always call the patient another 3 or 5 days later and look for it. And if you see it's further evolving, then there would be an indication for imaging. And of course, if you are more liberal, you would say that, okay, image in all young people less than 40. But sometimes we have to make our considered decision because of the cost of the imaging or other problems. Similarly, young children, if it's a congenital third nerve palsy, you may or may not do an imaging. If you feel that it is a congenital palsy, there is an amblyopia already, it's not a recent problem, and he has come after, let's say, 4 or 5 years of age, unless you are doing an academic exercise to know what is the extent of third nerve involvement, when you would have to do a very specific protocol of MRI with high definition, you may spare the imaging to be done. But whenever there is an acquired third nerve palsy in young people, you need to do an imaging.
I'll just add that one should also remember that some of these aneurysms can be having a painful presentation.
Yes.
So if there is like a headache, overnight headache, and in the morning patient wakes up with a ptosis and a ophthalmoplegia, certainly an MRA would be indicated more acutely.
Agreed. Yeah.
Next one is, what are the factors contributing to the development of contracture of muscles in case of paralytic squint?
Sorry?
What are the factors contributing to the development of contracture of muscles in case of paralytic squint?
So in cases of paralytic squint, if they're long standing, so the eye is deviated on one side, depending which muscle is involved. And because of the long standing thing, the muscle itself goes fibrotic change, which leads to contracture.
Basically, it's just like the fibrosis that is setting in of the unused muscle.
Because the muscle is
Prior
not
to fibrosis,
used,
a muscle spasm, that may be initial phase and then later on fibrosis. So in the initial phase, the spasm is happening because you have a long-standing palsy, and like in this case, the lateral rectus would be going into a contracture initially and then having a permanent fibrosis changes, right?
Yeah.
And you have to do an FDT at the first sitting in the clinical setup. You can look for an FDT and see if it is tight, then it means there is a contracture.
So one can imagine, for the postgraduates, that the lateral rectus is all the time in a contracted state. It then stays like this. For a healthy lateral rectus, it must stretch. And for that, the antagonist should be pulling it now and then. So if the medial rectus is gone, it's constantly in that position, it will kind of get solidified there. Gets rigid there.
Next, what explains painful ophthalmoplegia in case of third nerve palsy? Why is this painful ophthalmoplegia?
So pain, generally headache, as Dr. Amitava also pointed out, is a sign of compression, headache per se. But sometimes you may have pain in ischemic third nerve palsies also, maybe because of the vasa, the nerve supply which the nerve itself has. So that itself may cause pain. But headache associated with nausea or features of raised ICT is a sign of compressive lesion.
In addition, the migraines and ophthalmoplegic migraines particularly, they may have a third nerve palsy with a migraine, and you have the orbital apex syndrome, which Dr. Swati was mentioning. Those are also a situation in which there is a sort of granulomatous reaction, which is causing an pain. And in that particular situation, you may have to give steroids, and you find that there is a relief. And maybe for 2 or 3 weeks, if you give oral corticosteroids, they resolve. So these are some situations. The pain is different in each type. In the orbital apex syndrome, the migraines, there is a different pain. The pain with aneurysm is very acute, sudden pain, which is bursting headache. It may be very, very strong, something which you can't even bear, because sudden bursting is happening and the meninges are getting stretched. So there is a different kind of pain which is there in these. A chronic diffuse pain may be there when there is a compressive lesion, and if there is associated papilledema which is causing a raised ICT. So there are different kinds of pains or headaches associated with different situations.
Amitava sir, anything you would
No,
want?
it's been covered completely.
Okay. How different is our approach in a case of pupil involving versus pupil sparing third nerve palsies?
I think we have already discussed this question, so I would repeat it because this is the most common question and it's very important as well. So if it's a pupil sparing, again, you have to see whether the ophthalmoplegia is complete or partial, because partial ophthalmoplegia still suggests that it may be an evolving third nerve palsy, and you have to observe that patient very closely. For that matter, you may have to observe the patient daily. So at any moment, if there is pupil involvement, you will have to do neuroimaging. However, again, if it's a pupil involving third nerve palsy in young patients, as I said previously, as we discussed previously also, you need neuroimaging. In old patients as well, you have to observe them very closely and see if there is any improvement or not. Because if it's a vasculopathic third nerve palsy, they generally improve within first 4 weeks or show some kind of improvement. If there is no improvement, it is important to do neuroimaging.
In addition, I think just to extrapolate the condition in which there is pupil sparing, what tests to be done? I mean, that also may be talked about, that you will have to look for the common problems, which may be like hypertension, uncontrolled, diabetes, which is uncontrolled, any history of coronary artery disease, or any situation, I mean, lipid profile you need to investigate to see that there's a comorbid situation. And recently now we know that even the homocysteine is another thing which may come out to be positive when other tests are not there. So this is the battery of situations that you need to do. And the most common culprit which we found in our study along with Dr. Swati in RP Center, we found that it was the diabetes which was the most common culprit which was seen. So diabetes along with hypertension may be the second most common situation.
The next one is like the sixth cranial nerve palsy. Can third cranial nerve palsy also present as a false localizing sign?
Not exactly, because sixth nerve palsy, as we all know, is because of the compression of sixth nerve at the petrous ligament. So you never know at what level the involvement is there. But at third nerve, generally, if there is a compression or papilledema for that matter, you know probably that's at the level of subarachnoid. Why? Because the herniation will occur at that level and the third nerve will get involved at that time. So it's not a false localizing. You can localize probably at the level of subarachnoid space in such cases where you have papilledema.
Next is, can you elaborate on pseudo-orbital apex syndrome?
Pseudo-orbital apex syndrome. Orbital apex, what do you mean by? Yeah, myasthenia probably is one such condition which may present, but of course, in those cases, vision will be normal. That you have to understand, as compared to an orbital apex syndrome, where there will be optic nerve involvement. So generally, there is an external ophthalmoplegia in myasthenia. Pupil will be spared. So even though on looking at it, it may look like that there is complete ophthalmoplegia, so you will be in hurry to localize the lesion at the orbital apex, but then again reassess the vision. If it tells you that there is no visual involvement, if the corneal sensations are normal, then you can be sure that there is no lesion at orbital apex.
Any comments from Amitava sir?
One condition I can think of as pseudo-orbital. Any comments?
You muted.
Sorry, I haven't heard of this pseudo-orbital apex syndrome.
I haven't heard. So I just thought maybe.
Yeah, Swati has actually thought of something and put it in right now. Excellent.
So basically, I mean, the superior orbital fissure versus the orbital apex syndrome, as Swati was mentioning. So superior orbital fissure syndrome can be sometimes to differentiate it from an orbital apex syndrome, the classical Tolosa-Hunt syndrome. And the differentiating feature is that it is sparing the optic nerve. In the supraorbital fissure, it is involving the third nerve along with the other nerves in the supraorbital fissure, but sparing the optic nerve. So that would be the differentiating situation.
And the last question for the day is, does aberrant regeneration occurs in non-compressive third nerve palsies?
Trauma is another cause where aberrant regeneration can occur along another other than compression.
That's it. I think we have wrapped up the questions for the day. I think we are early today. Any comments, sir? Amitava sir, Pradeep sir, before we conclude?
So once again, I would say that it was a wonderful presentation by Dr. Swati, a very, very comprehensive talk on third nerve palsies on the different aspects. And I'm sure this will be really enjoyed by the PGs and one of the most viewed topics. And I would like to thank Dr. Swati, Dr. Shefali for moderating so well, and my co-chair, Dr. Amitava, for taking up the additional questions that were there. So thank you.
Thank you so much, sir. Thank you.
So next we'll meet on the coming Wednesday, which is September 14th, with the 4th and 6th nerve palsies, the etiology, diagnosis, localization, management by Dr. Arun. So see you all on the coming Wednesday.
Bye.
Thank you.
Thank you.
Thank you.
Bye-bye. Yeah.
Bye.
Bye, Swati.
Bye, sir.